Welcome to the fifth installment of the Alliance Transplant C-Suite Snapshot Webisode series. For this installment, we're focusing on transplant contracting considerations. We're pleased to be joined by Mindy Scharlin and Alexander Aussi. Mindy Scharlin has been working in the field of managed care contracting and transplantation for nearly 30 years. For the last 22, she has worked for Stanford Hospital and Lucile Salter Packard Children's Hospital in Northern California. She currently holds the position of Director of Transplant Contracting. Mindy has been active on a national scale through her membership with the Transplant Growth and Management Collaborative and the Health Resources Services Administration. In addition, she's a member of the Products and Services Committee of the National Comprehensive Cancer Network. Alexander Aussi has over 30 years of experience in healthcare, 27 of them in organ transplantation. He has extensive experience in transplant administration, new transplant and VAD program setup, marketing, managed care relations, contract management, and audit of Medicare acquisition cost centers. At the 2014 UNOS Transplant Management Forum, Alexander received the prestigious Heckenkemper Leader in Transplant Administration Award, a peer-driven award presented annually to an individual for distinguished leadership in transplant administration. Alexander is now the Chief Executive Officer of Guidry and East, the largest transplant consulting firm in the U.S., and oversees the clinical operations and transplant finance consulting functions of the company. To Alex and Mindy, we're pleased to have you with us, and I'll turn it over to you to begin our program.
Hey, my name is Alexander Aussi. I'm CEO of Guidry and East, and we're going to be talking today about transplant contracting.
And my name is Mindy Scharlin. I'm the Director for Transplant Contracting at Stanford Hospital and Lucile Salter Packard Children's Hospital, and I'll be joining Alex today.
To start with, we're going to be talking about what the current market looks like and what does the current market contracts look like, and discuss a little bit about why do we need a network per se. Now, as you probably know, payers are building specialty networks for procedures that tend to be very expensive. The most common networks are those for transplantation and oncology services. There has been a surge of other networks out there for, per se, orthopedics, dialysis, infertility, and other. Now, transplants are the most expensive of all the technology used nowadays in transplantation, which is why payers set up specific reimbursement methods to budget and manage these high costs. Now, payers have a responsibility to contract with competent providers that have expertise in providing tertiary and quarterly services. To become a part of a transplant network, the top-tier level, otherwise known as Center of Excellence, the hospital must maintain a certain transplant volume per year and a certain level of survival outcomes. And each one of these payers have pretty much their own independent criteria as well when it comes to the number of transplants done and the outcomes that are expected. Now, each payer, as we said, has its own qualifying criteria for that COE designation. And the transplant's quality outcomes, as you probably already know, are available, and this is publicly available information at www.srtr.org. Which is a scientific registry of transplant recipients. It's a national database of statistics related to solid organ transplantation. Now, stem cell transplant outcomes are reported separately by the American Society for Transplantation and Cellular Therapy. There are some talk about stem cell transplant becoming BMT in general, following the same guidelines of transplantation when it comes to billing and reimbursement. However, the ruling regarding stem cell transplant has not been finalized yet. I think, Mindy, what do you think contracts are based on?
Well, they're based on volume and outcomes, as you just mentioned. Every payer has their own criteria, although much of the criteria is similar between the payers. And the payers have to verify every year the data. They have to verify the quality for their clients. And the contracts are also based on the experience of the physicians and, most importantly, the outcomes. And all the information on outcomes can be found again on the SRTR website. The payers also rely on the publicly available cost reports, which every payer can access online. And so they look at hospital costs as well. So let's look at the next slide and talk a little bit about how these transplant agreements are different from the med-surg agreements that you currently have. Now, the structure for transplant agreements is quite different. The structure is based on the various phases of care. So the first phase is the evaluation phase, which varies from, usually it's outpatient, but can be inpatient depending on the severity of illness of the patient and the organ. Mostly those services are outpatient, and mostly they are reimbursed based on your current medical surgical agreement. Then there's the phase of the pre-transplant, or what we call maintenance care, which is the services that are necessary to maintain the health of the patient, so when they get an organ offer, they're well enough to accept it. Again, those services are most commonly reimbursed based on your current medical surgical agreement. The transplant event is the biggest piece of the contract because it's pretty much where the big money is. The transplant event most often starts 24 hours or the day prior to the transplant and goes until discharge. The fourth stage would be the post-discharge follow-up care, and that usually is somewhere between 30 to 90 days, depending on what your clinical protocols are. So those are the main phases of care. Sometimes the networks, who are not the payers, but they are the transplant network, they have follow-up care that goes for a whole year. But with the insurance companies, usually the follow-up care ends around 60 days post-discharge. In terms of the reimbursement, I did mention that the evaluation and the pre-transplant phases are paid for most often under your current agreement. And the post-discharge care is most often wrapped into the transplant event rate. Those are most often case rates. And the case rates usually have some kind of outlier protection. This is a way the hospital can share risk with the payer, as well as building in some financial protection. The protection we call stop loss, and stop loss can take different forms. They can be a second dollar stop loss. It can be based on a per diem, which would mean your case rate would have a number of inlier days. Or the stop loss could be a never less than clause, which we call a floor. And these are not too common anymore. Most often we see second dollar stop loss or per diem stop loss. So Alex, on the next slide, would you like to talk a little bit about some of the language considerations for these contracts?
Absolutely. It is extremely important to be very specific and clear with the language for these type of services, including all contract language such as in full, which is problematic from a cost reporting standpoint. It is our understanding that payment in full is a legal obligation to be in such contractual agreements between the payer and the hospital. However, if you include it as is, meaning if the wording is as is, payment in full, it may preclude the hospital from going after additional funding from the transplant cost report at the end of the year reconciliation procedure. You have to be very, very careful in the way you word your contracts, and also in the way you include or exclude specific cases from your case rate. If you have a very complicated case coming in, and you know that this particular diagnosis carries with it the need for high-cost drugs and or new technologies out there that is going to help this patient to be bridged through the transplant process, or as part of the transplant event itself, you probably need to be very careful about creating specific exclusions in your contract regarding these cases. Mindy, as someone who negotiates for a large hospital, what are the current challenges that you see in your experience?
Some of the current challenges have to do with not only the increase in managed government plans, but also the health plans decreasing their rates and trying to shift the majority of the financial risk to the hospital. Now, many of you probably see in your market, there is a large increase in managed Medicaid plans and managed Medicare plans. And there is a big movement right now for states to delegate this financial risk to the health plan. So the government is no longer paying for transplants, they're delegating it, and these plans now are coming to us and asking us for extremely competitive and low rates for this population. I would want you to err with some caution on these rates, because many of the plans would like you to accept reimbursement that is either at 100% of your current state rates or the DRG rate, or they want you to actually take less than that. So a word of caution for the government plans. So yes, that's a lot of the challenges that we see, and more financial risk with lower rates being, we are being asked to accept lower rates and decreasing our revenues every year based on competition. All right, so Alex, you've been a transplant administrator at various hospitals throughout the country. What do you think are some of the key factors at building a successful program?
So one of the key factors there that you alluded to a successful program is having a fairly strong infrastructure that starts from having your financial coordinators who verify insurance, request authorizations, to the dedicated billing staff who manually package the claims and track reimbursements. And in between, we've got the charge vault coordinators who review pretty much all the charges generated on behalf of your transplant programs for applicability on the cost report. Now, organ transplant reimbursement is a cost-based service per medical guidelines. It is directly affected by how the managed care contracts are drafted and executed. Benefits can change while patients wait on the waiting list, so regular follow-up is also crucial. And this is where waitlist management comes about as a reality and a need for the transplant program. In addition, new authorizations are needed for ongoing lab testing necessary for appropriate matching at the time of organ offers as well. Every program should have strong managed care teams that are closely aligned with transplant administration, who can assess contracts and negotiate agreements with non-contracted payers. And this comes as a result of a higher collaboration between the different hospital departments, as well as having clear financial expectations for contracting and reimbursement. Finally, access to data and the ability of both the transplant program and the managed care contracting teams at the hospital to access data relevant to the programs and to model this data accordingly is key to have a successful program.
I'd like to add to that, Alex, just if I may, that every hospital houses their prior authorization specialists in different departments. They could sit in transplant or they could sit in admitting. I think it's really crucial also for the transplant administrator, the case managers, and the managed care department to have close working relationships and regular communication with the prior authorization team. So I just wanted to end saying that.
It takes a village. It takes a village.
So, in summary, what I see on the horizon is the expansion of specialty networks in the market. For example, Centene, they will be entering the market in 2020, and they will be developing their own transplant network. Historically, the plans in the various states where Centene exists have negotiated their own contracts. And they've also used one of the largest transplant networks for some of their transplant business as well. But because they are so large and they have 32 managed Medicaid and Medicare plans in the United States, they are now going to be developing their own network. So that is going to be happening very quickly in 2020.
I would also say, staying on top of your outcome data as a transplant program is really critical. As we mentioned earlier, Center of Excellence designations are really based on volume requirements and outcome requirements. So the better your outcomes, the better your chance at getting favorable contracts. Your program outcomes are public, and they're released twice a year through the Scientific Registry for Transplant Recipients, SRTR.org. And, again, having the appropriate resources within each program to support your operation and preserve your outcome is really critical.
It's really extra important to maintain close relationships with your colleagues, both internally as well as externally. Internally, make sure that you're meeting with folks on a regular basis to keep each other up to date. And then externally, working on a win-win negotiation every time with the payers, working collaboratively goes a very long way.
Yeah, and at the end of the day, whatever your mission is, as a hospital system, if you're not covering your total cost, your mission is going to run out the window. So it's very important that you understand your transplant cost reporting, that you understand the cost report, and you also understand how contracts are covering that delta remaining, between your direct cost and total cost, and how contracts should be able to cover your total cost at the end of the day.
We are going to leave you with a slide at the end for both Alex and myself's contact information. If you have additional follow-up questions, please don't hesitate to email us or give us a phone call. Thank you so much.
And thank you for having us.
Our thanks to Mindy Scharlin and Alexander Aussi for their fantastic insight, and our thanks to you for taking the time to view this valuable program. If you have any questions or feedback for our presenters, please connect with us on social media or on our website at organdonationalliance.org. We'll see you next time.